Good evening, everyone, and thank you for attending AACP's webinar with Dr. Angela Tenholder, presenting Invisible Influencers, Challenging the Paradigms of Oral Restrictions and Sleep-Disordered Breathing. I'm Shaylin, the Association Manager for the AACP, and I will be the host of tonight's webinar. This webinar is approximately 50 minutes, followed by a 10-minute Q&A session. Please enter any questions you have in the Q&A box at the bottom of your screen, and we will address them at the end of the presentation. The AACP has no conflicts of interest. Registrants can expect to receive a recording of this presentation via email within 5 to 7 business days, and attendees will receive their CE certificate of attendance within 30 days of the webinar air date. I would also like to take a moment to mention some upcoming events for the AACP. Our next complimentary webinar will be Scott Manning presenting Increasing Case Acceptance for TMJ and Sleep Patients on July 13th, and the Medical CBD Crash Course for Healthcare Professionals with Dr. Gregory Smith on July 23rd. I would also like to remind everyone that AACP's 37th Annual Symposium will take place in Spokane, Washington, August 12th through 13th. And tonight for the webinar attendees, we're offering a special of 15% off of registration using the code INVITE, and you can register at aacfp.org. I would like to introduce our speaker, Dr. Angela Tenholder. Dr. Angie is a general dentist, is board certified with the American Board of Craniofacial Dental Sleep Medicine, and presently serves as the president on the DABCDSM Board of Directors. She has achieved fellowship status in the American Academy of Craniofacial Pain and currently serves as the chairperson for the AACP's Board of Directors Education Committee. She has years of experience as an instructor with the Synergy Academy and the ELF Interface Academy. A combination of professional guidance and personal experience has allowed her to use her knowledge as a former chronic pain patient, a parent of children with orofacial challenges, and a provider of patients with medical challenges to creatively utilize the many tools available to her, including ELF therapy, Oralace, and Baby Lace services. She has been providing Oralace therapy daily in her general dental practice since 2018 and is the developer of Baby Lace. And with that, it is my pleasure to turn it over to Dr. Tenholder.
Thank you, Shaylin. I'm going to turn off my camera. I'm going to share my screen because I want everyone to focus on the content on the slides. There is a lot of information that we're going to be going through in a very short period of time. So I'm going to ask everyone to hold on with me and do your best to write down questions and make sure that you email them if we don't have time at the end to go through them, because I really want to focus on the content, but I really want to be there for you guys too, because there are some challenging paradigms that we're going to be talking about. I love this elephant, the drawing, because basically all of these scientists are looking at the same thing, different parts of it. They're blindfolded and they're wondering, is it a sphere? Is it a tusk? Is it a wall? Is it a rope? And how are we supposed to have clear vision of our role as doctors and therapists if we ourselves have a blind spot of what it is that we're looking at? And my goal is to provide you with some basic information on some of the principles and concepts of these invisible influencers and allow those who want to learn more to do so at their own pace, because some people are going to want to dig in and roll around in it, and other people, it's not going to be comfortable for them because sometimes it's not easy to hear new things. Shaylin already disclosed this, and our housekeeping events. Our learning objectives are to understand the limitations of many of our current paradigms and understanding tongue restriction and the neurological implications of that, and create value in evidence-based medicine as well. We're using a basic science code, and the literature references for these presentations are available using that URL website link. So buckle up, everyone. Here we go. Shaylin did a fantastic job of introducing me already, so most of this has already been covered, but I want to go over my two most important jobs are being the MOM and the MRS. I had to learn to fix myself, my kids, and my husband. So my husband has sleep apnea. I had craniofacial pain. One of my children has a movement disorder, and the other one has TM joint problems because she had a facial injury in first grade. So I had to learn all these different things, and this is just a short list to be able to put it all together and problem solve continually to be able to be a perpetual student. And I'm going to give credit where credit is due. My mentor, who was not an easy man to follow, is Dr. Derek Nordstrom. Some of you guys may know this, but a lot of you guys don't, that he was the creator of the original dorsal mandibular advancement appliance. He also created ALP therapy and Orlays. Dr. Gabor Mate is someone that I would like you guys to really look into when I'm talking about early childhood trauma and how that impacts neurological development, which impacts physical development, which is of course something we're all very interested in. He is an MD, so his research on the role of addiction and compulsive behaviors in adulthood, tying back to early childhood along with physical illness, is very impactful. Dr. Nikki Mills is an ENT from New Zealand who decided to really dig in deep, literally, pun intended, to figure out what's going on under that tongue, because she was a clinician and then she went into research to find some answers. And I want to give honor to those who work with the primitive reflex system, because I wish I would have known that earlier in my career, and why we weren't taught that in dental school, I'm not sure, because it is a super impactful part of how the human body develops and works. Cranial nerve dysfunction is another huge thing. And the role of cranial osteopathy and the role of fascia as it impacts physical and emotional health. I want to thank all the people that I've learned from. And everyone has their own tools they're using, and there's blind spots that we might all have when it comes to our different schools of thought. And if you can meet the needs of your patient, choose whatever tools work for you. I've already shared what I used to work with mine. And I have been around long enough, been in practice for 27 years, to realize that sometimes I thought I knew something, and then God said, here, hold my beer. I'm going to tell you that you might not know everything you need to know, so I have to keep looking. And as I mentioned before, Derek Nordstrom constantly keeps me challenged because he has been the one who developed the dorsal appliance and then realized that they were non-responders, and he kept looking. And some of that information you're going to be able to hear about today. The Dunning-Kruger effect is where I swing on a daily basis of I think I know it, to trust me it's complicated, and I'm not sure if I'm ever going to be able to understand it. But we have to be open to learning new things, just like we're asking our patients to be able to learn new things and to be able to move their mandible in a different place, or learn how to breathe differently, or learn how to swallow differently. We as providers need to be open to that as well and have realistic expectations for ourselves and our patients. Because challenging paradigms in politics is not easy. For those of you old enough to understand who Rodney Dangerfield was, you'll understand some of the impact in that slide, because it's a tough crowd sometimes. It's not an easy thing to say, because almost everyone is looking for simple solutions to complex questions. And sometimes there's a presumption of the problem. Oh, we know what they have. Not always. Sometimes it's the restriction that we think that we should be helping the patient with is not actually their primary restriction. And compulsive consumerism is all over social media. How many millimeters of intermolar distance? Or here, can someone take a look at this picture I took with my camera on my cell phone to tell me if I have a tongue tie? Did I have it cut enough? Was it, do I need to do it again? And then we do have contamination and collaboration in our professional communities. Sometimes it's wonderful and sometimes it's not. We need to really be collaborative in our approach and be open-minded to the people who are willing to teach us some new things. When I started doing my research on some of my presentations I've done before, I wanted to find the source of the serenity prayer. And I thought it was this: God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. That's not actually the original serenity prayer I found out. The difference is that courage comes first. There's insight instead of wisdom, but the serenity to accept stays the same. Sometimes we cannot change things if we don't know what we're looking at. I'm hoping to share some of those things with you. Because have you ever tried to go somewhere where the emergency brake is on? It just takes a whole lot more effort. And this has actually happened to me a bunch. And my mind is like my internet browser. I have 19 tabs open, 3 are frozen, and I have no idea where the music is coming from. That's the role of trauma and limbic hypervigilance and autonomic nervous system dysfunction and anxiety that a lot of our patients have, whether it started with the pain or ended with the pain, or started with the sleep disordered breathing, and now it goes into being stressed out about it. There's a lot of things that go back to early childhood and that development that I was mentioning earlier, that if we knew what that emergency brake was, we could take it off, our patients could go through treatment more easily. We're going to take a deep dive in some of the underlying and impactful aspects of oral neuromyofunction. We're all familiar with the phrase oral myofunction, but we're going to bring the neurology into it and the sleep physiology that should be considered in a comprehensive approach to patient care. And if we figure it out early and we know what we're looking for, including childhood trauma, limbic hypervigilance, retained primitive reflexes, and the trigeminal cardiac reflex, we can start sifting through some of these things and helping our patients overcome their obstacles earlier in life. And I'm going to do the best I can to get through this as quickly as possible. So forgive me for talking fast. Unfamiliar sensations make it difficult for people to want to do new things, including learn. And we build on familiar sensations to grow. We seek pleasure and avoid pain throughout our lives. And sometimes that pleasure of doing the same thing over and over again is seductive, and it keeps us from moving forward. We're going to be talking about oral neuromyofunction, not in the context of just the tongue, but the role of the buccal neuromusculature, the orbicularis oris, which is the pucker muscle, the buccinator, and the superopharyngeal constrictor, which is the airway corset, the floor of the mouth musculature, and of course, the masseter muscles of mastication. We're going to be looking at the role of retained primitive reflexes in adverse childhood events. Retained primitive reflexes, as an overview, are a set of downloads that we have when we are developing. In utero, the first one is fear paralysis reflex that protects us from surges of maternal cortisol. And basically, the baby paralyzes in utero, so we don't share that with them. It's supposed to turn into the startle reflex, which is the Moro reflex. And that retained primitive reflex of Moro is supposed to integrate at about 4 months of age. So the startle reflex normalizes. In a baby, we can do a little drop with them and the arms fully extend. So they extend and then they flex. If we're doing that as an adult because we don't feel safe in our body, it keeps our fascial system tight. And we all have those patients in a chronic pain office where the fascial system is tight. Identifying and working through it will make your cases go so much easier. I'm looking at the whole person for the whole lifetime, not just the temporomandibular joints and not just the tongue and not just the airway. We're looking at homeostasis because as human beings, we're supposed to be able to breathe without a piece of plastic or without a breathing machine to help us. And that background noise of trauma has been underestimated. We are not taught about it. But Gabor Mate's work is very, very impactful with helping us understand these things. And it's going to be a big part of the future of medicine. And we can learn it the easy way or the hard way because interruptions in normal development create compensations and adaptations that are harder to deal with an adult than with a child. Chicken and egg, we deal with it every day. So is it the interruption that caused the problem in development or the other way around? And when our patients are doing something, clenching, or they have Tourette's, or they're not breathing well, or they have sleep fragmentation, how do we help them find out what it is that they need to do if it's not an obvious thing? And our patients deserve better because we need to be looking forward in medicine. The research that we really need to read is what is being developed right now, not what's already been done. And all medical progress was first seen as quackery. And some of this stuff might sound crazy to you because you haven't heard of it before, but we need to be open. Because sometimes with our patients, whether it's a tongue tie, how many revisions and releases are we going to do on these patients thinking it's not a complete release? Or how many airway surgeries or how many appliances? We need to be looking deeper. And it's easy to be down on things when you're not up on the many factors considered here. So please have an open mind. Maslow made this model for us with overall hierarchy of needs. I'm going to be translating that from an overall hierarchy of needs to what, in my opinion, our brain needs. And this is based on the instruction of my mentors and the research that we roll around in all the time. Physiological needs, safety, connectedness, emotional, and self-actualization and growth. When we look at what the brain needs for the brain-body connection is sustenance, safety and intimacy, growth and fulfillment. And we're going to be going over those requirements and how we can meet them. Because a lot of these things we're not really taught about in dental school. Cranial nerve balance, why is it that they need to be balanced? Proprioception, our position in space, the natural signaling. We're in we're living in an amazing unnatural world right now, even though we're animals trying to function in it and feel normal. The primitive reflex system, as we talked about, the Moro reflex is the gateway reflex. There's many, many primitive reflexes that are supposed to be here to protect us during a part of development. And then they're supposed to integrate and go into a postural reflex and go away. But if they kind of stay around too long, it's kind of like the mother-in-law that comes to your house to help you when the babies are born. And then they're supposed to go back home and then they stay. What intended on being a helpful time in your life ends up being overstayed. So when we have a primitive reflex that hangs on, it's not helping us anymore. It was supposed to, and it can help us get through a tough time, but it can get in the way of development. Gabor Mate's work talks about the impact of adverse childhood events, especially perinatal and up to 3 years of age, that most of us don't even know about. But if we have a 43-year-old in our office that's really dealing with an issue that happened when he was 4 months old or 2 years old, and that injury happened, then we need to be understanding how to treat that child. It was still in the body of that adult. The trauma's been stuck. We all know about AHI, apnea-hypopnea index, RDI. Sleep is more than just one number. We're going to be talking about stage 3 sleep and glial cell function in reference to neurodegenerative conditions. Hyaluronic acid. We all think about that as maybe something for wrinkles, but hyaluronic acid is the glue or the glue. It's supposed to move and be fluid in between the deep fascia and the epimysium of skeletal muscle. If it is restricted due to lack of movement or trauma, that creates another restriction that should be released non-surgically prior to a surgical release to allow for improved tissue mobility. And if you interrupt the epimysium of the muscle during a surgical intervention, you obliterate that hyaluronic acid interface and create a secondary scar. Good intentions sometimes have bad outcomes, and we're just really not taught these things. And what does this have to do with dentistry and airway and tongue tie surgeries? We just want to grow the face, right? To be able to make sure they have that airway. And if we perform a tongue tie release or we create some kind of expansion of some kind, won't it fix everything? Does function always follow form? Not necessarily. Keeping up with the research shows that how many of us were trained in the ABCs of airway? They updated it, and now it goes in a different order. Now we want to maintain the circulation to the brain. We should be doing the same thing through our dental appliance therapies and anything to be able to help that patient live a better life. Cerebral blood flow for nutrition and oxygenation. It's not just about an airway. It's about how the oxygenation is able to support the brain. And the metabolics. We need to assess for structural and non-structural airway and oxygen carrying capacity restrictions, including ferritin levels, iron, because if we make an airway and their hemoglobin can't carry it, we also have an issue. We're figuring that out with COVID, with low oxygen sats, and we need to reduce or remove the obstacles at all possible. But that's the second thing, not the first. And then the third one is to support the breathing until the patient can do it for themselves. Traumatic brain injury. We all know about concussions, but those things derail neurological development, and traumatic events, even though it might be a blow to the head, it's still inflammation. And that we need to support that patient's ability to be resilient enough to overcome their obstacles. And that is through the mental dental connection that we'll be discussing. Brain dysfunction and intracranial inflammation. Another thing we learned about with COVID and long-standing implications in cranial vault mechanics and the bones of the head gently moving around each other and sliding like the tectonic plates that are underneath our feet that we only feel with an earthquake or we see with a mountain range. Those cranial bones do move. They do. And we need to understand the injury. And it's not only physical injury, because The intracranial inflammation is more than physical trauma. The research shows that emotional and physical pain activate the same areas of the brain, which is why Gabor Mate's work is so impactful, because basically he's saying that this gets trapped in the body. And if we're just treating someone with a splint, we might be missing out on how to really help them. I want everyone to think about redefining a restriction. If you are in car number 3 and you're at a stoplight and the stoplight is red and then it turns green, you want to go because that restriction of the stoplight is now not holding you back, but the 2 cars in front of you still might not be moving. Therefore, they are also restrictions. Imagine in car number 1, we have a neurologic stress response doing that. That could be cranial nerve dysfunction. Car number 2 could be fascia. There's fascia under the tongue. These are the kind of things we're going to be discussing in the next few minutes. And oral pharyngeal airway is only one component of that cerebral oxygenation process. An autonomic nervous system signaling and the hierarchy of needs to make sure that that brain has circulation is really important. And what can make the fascia more rigid? Retain primitive reflexes, the stall response being active. And we need motion to do that. Fascial restrictions prevent motion. Chicken and egg. To look like a posterior tongue tie though, right? Car number 1, neurology. It needs fuel, which is glucose metabolism. And if we have a civilization that is sugar dependent and doesn't learn or have the capacity to learn to store glycogen in the liver, and they need to move and clench at nighttime to release glycogen from the skeletal muscle to fuel the brain to sustain REM sleep, that's a big aspect that we are missing out on, and it's impactful. And it really helps people when you can help figure it out. Emergency brake are the retained primitive reflexes, and we have a generation of people with lack of myelination during development due to low iron levels with BOM. Car number 2 might be that fascia in this analogy that could run right into the back of car number 1. And if that cervical spine is out of alignment at birth and the fascia forms around it and it's not addressed, that fascial system that's developing in that baby remains that way until treated. The oral neuromusculature, imagine that is car number 3. Oral neuromusculature is the soft tissue. The tongue function and mobility, the cranial nerve influences, the cervical, and the ANS modulation. But it's inside of that bus that carries the pretty red white things as well, which is, if the bus is the cranial vault, the maxilla, and the mandible, the teeth are just the passengers on that bus. And that bus grows through certain kind of stimulation to bone. And Alexandra Pepton, who is now Alexandra Porfor, and her research figured out that current devices in dental facial orthopedics rely on the application of static forces, and converging data from their work and in the present study suggests that cyclic forces induce more effective bone growth than static forces. But a lot of our appliances are static. RPE, all the different ones that are out there, different variations of static appliances, are not getting the effective bone growth. And that's why I love my ELF, because that is tensile cyclic loading on the cranial sutures. And that's why we need to be looking at the research, and taken together, the present data may have implications in craniofacial orthopedics. So brief doses of cyclic forces in either tension or compression may effectively stimulate sutural growth. Something to think about. Because if we don't do all the things right in the right order, there can be a crash. And so treatment sequencing is important. And what if the development of the dysfunctional swallow was the crash scene? What if it was always wrong and it was never fixed, never addressed? We just did expansion. We might have had a blind spot. We might have not have known where we were going, or maybe we didn't ask for help or directions along the way. When I was looking for slides to understand or to help communicate the role of interruptions and developments, I was thinking about Wheel of Fortune would be fun. And there's some just really inappropriate Wheel of Fortune things out there, by the way. So I finally found one. Said, don't get the tit bit in the pit. I'm like, okay, I can use that. And my husband was like, oh, don't let the cat out of the bag. I still don't see that because I learned it the wrong way first. Ever remember someone's name the wrong way the first time first? That is what sometimes kids do. They don't have a normal developmental sequence that is supported. And the picture on the left is the guy fixing the bridge that I see out of my office window. And we have a big earthquake line going through our area. I want to take time for that guy to do it right. I don't want him to rush through that, because if that bridge goes down, it can hurt a lot of people. And we need to understand those interruptions and also take the time to address them. because that frenulum and pendulum is swinging really hard. And I love this most interesting man in the world. I don't always talk about tongue tie, but when I do, I mention posterior tongue tie and lip ties often go together. And we are in a swing right now between if we should see it, we should cut it. And just because it's there doesn't mean we need to do anything about it. This is where Nikki Mills came in, and she wanted to understand why some of her tongue tie surgeries were effective and some weren't. And what she found out is that there's a variability in composition between people, and that degree of distensibility challenges the dogma that all lingual frenulums are non-distensible, and that frenulum morphology can be different. And she also found out that the lingual frenulum is a fold of fascia. It is not a band. It is not composed of connective tissue fibers that have an AP orientation, nor is it a discrete quarter band as often described in the literature. In fact, she found out with postmortem dissections that the frenulum has a basket weave orientation that is fascia as it crosses the midline, and therefore the diagnosis and classification of a posterior tongue tie is based on the construct of a midline submucosal band and is not supported by her dissections. Interesting, right? Imagine the mucosa being the red line, the fascia being the green line, and the striped area being the muscle of the genioclastis. Really hard to tell the difference visually between the three. Basically, she said you cannot tell by looking at someone what kind of lingual anatomy they have. She said the floor of the mouth fascia is continuous with a superficial layer of connective tissue in the ventral tongue with no deep extensions into the genioclastis and no fibers extending directly into the median septum of the tongue. And they found that no evidence of tongue restriction caused by deep connective tissue or genioclastis. Therefore, there is no indication for deep incisions into the muscle. In fact, if you do, there's increased pain, local inflammation, increased scarring, and potential paresthesia to the tongue. And babies and littles can't communicate, hey, listen, I can't feel that side of my tongue anymore. So we need to be very, very careful with these decisions. This is another article, the Martinelli article, that the posterior frenulum did not interfere with sucking and swallowing during breastfeeding and didn't recommend surgery for any of the subjects. So why are there so many studies that show the exact opposite? And there are, but that's why I'm here to challenge some of you, because you might only be seeing the ones that you're being shown. This is my mentor. I'm going to take a moment to read it. And he has arrows in his back, and we're both taking heat for this, but this is his truth. The myth takes. Because visceral swallow, infantile, involves more AP tongue protrusion and motion, these patients may initially experience a nice outcome with surgical release, but rarely experiencing a conversion to a mature swallow because of the misunderstandings surrounding the underlying neural integrative causes. Cognitive habituation does not equal true conversion. If the surgery provides a temporary mechanical release but adversely alters neurological connectivity, it becomes more difficult for the patient to make the conversion, although the conscious habituation is possible, which means they can do their suction hold, but they can't swallow effectively still. Dentists tend to be visual as well as procedural, so it's easy for them to fall into the trap of pseudoscientific frenectomy and shiny devices like CO2 that make nice, smooth ablations, but they don't discriminate very well between tissue types and anatomy. Some providers can. Some providers have that skill, and I'm going to put that disclaimer out there. But some don't, because it's quick and it's easy. They're missing some of these anatomical cues. So it's important that doctors understand the anatomy as well as the principles behind the healthy release surgery. And that's why we have been working so hard to have people understand that there are things we can do to have a non-surgical tissue release. I had it done myself. Increase range of motion and ability to do a suction hold immediately. And we see it with babies too. But telling the truth comes at a price, because we've both been attacked for saying our truth. So is the Academy for Breastfeeding Medicine, when they're like, hey, we need to be a little bit more careful about how many procedures are being done. Because what their statement is that it's important to note that some of these surgeries and some of these restrictions are inappropriately attributed to an anatomically normal sublingual frenulum, which has been labeled as restricted. What is an incomplete release? How many times have we seen that? Oh, it didn't work, therefore it must not be complete. What if they're releasing the wrong restriction? What if the restriction was neurological or fascial and not an anterior tongue tie? But they didn't know any different. So Academy for Breastfeeding Medicine say, hey, we need to be really, really much better about this, because there's a lot of babies that are having great results, but there's a lot of babies that aren't, not long-term. And I see them in my office every day because my love language is science. And very few people share this love of science and literature with me. However, a lot of people like cartoons. My favorite, Far Side. How many times have you pushed very, very hard and insistently on a door that was supposed to pull open because you thought you just needed to push a little bit harder? Think about where our conceptual blind spots are, our visual blind spots. Can we see in between the mucosa and the fascia and the genial glasses down there? Can we see all those little bands on a baby especially? And what are the expectations of the parent? And are we overvaluing the honeymoon period of the therapeutic intervention with that rush of dopamine and human growth hormone that is intended to help us overcome an obstacle and trauma, but instead is perceived as this great surgical result? And how much value do we give to rationalizing the decision in retrospect? Let's go back to what the brain-body connection needs. Sustenance, blood and cerebrospinal fluid flow. We need a balance of parasympathetic and sympathetic and trigeminal influences to keep that brain working at its optimal capacity. We need oxygenation, and that's hemoglobin carrying capacity. Glucose, as I mentioned before, and stage 3 sleep. We need to understand that there is a normal sequence of tongue function that starts with the anterior coupling response with breastfeeding and feeding, and then as the teeth come in, a different set of rules apply. It's like a dog in a fence. It's happy. The tongue inside of the mouth is happy as long as the boundaries are, and the positive proprioception of the tongue liking its home is important. That'll get some people's attention right there, because intimacy is what we do in the mouth. And if we're not being aware of how intimate and the role of trauma is in this environment, we also might have a blind spot. Because neurology rules, it is before airway, it's before anything else. And the locus coeruleus is one of my very nerdy, amazing research articles that we're going to be talking about, because it is the balance of the brain using the trigeminal as its metric. So the growth and fulfillment is the top part of that Maslow's hierarchy, and the cue that swallow is important. And functioning with a balanced occlusion, as I will just go over in the locus coeruleus information, is part of that. And attaining a functional oral volume is growth. But there's things that come before that with physiologic safety, social, and emotional. The body will do whatever is necessary to maintain that balance. And it's more than oxygenation. If there's unresolved trauma holding the system back, it's not going to be able to work through it as gracefully. And we utilize the influence of our powerful trigeminal system to affect our autonomic nervous system tone through our oral neuromusculatures. And we can do it a graceful, easy way, or we can do it a hard, forceful way with clenching and pursing our lips. And where is our blind spot? Are we aware of all the oral neuromyofunctional deficits that are out there? Are we really aware of our sublingual anatomy and research? Do we understand cranial strains and restrictions? All of these different things might be a blind spot for you. I know they were for me. Treatment sequencing, as I mentioned before. And what if you're performing a surgical release in the presence of a neurologically based restriction? And what if that restriction has a component creating whole body fascial restrictions? Because that fascia being tight at the base of the skull and under the tongue and all through the cheeks could be misdiagnosed as a tongue restriction that requires a surgical approach. This is a quote from Gabor Mate. What seems non-adaptive and self-harming in the present was at some point in our lives an adaptation to help us endure what we had to go through. That people are addicted to self-soothing behaviors is only because in their formative years they didn't get to receive the soothing that they needed. People who have a lot of past trauma, they have a minor inconvenience like shown in the cartoon, and they fall apart. We need to help them through that, and we have the capacity to do that as dentists. Because that hyaluronic acid, if it's moving, it is a neurological mediator. When the brain senses hyaluronic acid, it feels better. When it gets in the blood and it's mobilized, it's a green light for the brain. And this is what fascia looks like at the different levels. And the whole body work that the stechos are doing with fascial restriction points, I also encourage everyone to look into. But if the patient has a retained primitive reflex, their fascia is restrictive, it can look like tongue tie, which could then negatively impact craniofacial growth and development, which then could have a reflection on airway insufficiency and cranial nerve dysfunction, which could look like a sleep disorder, which could also be misdiagnosed or accurately diagnosed as attention deficit and learning disorder, movement disorders, and cervical dystonia, and the list goes on. Because maybe the tongue isn't neurologically working in concert with the brain and the fascial system. We have probably all seen the homunculus model, but I want to remind everyone of the impact of the tongue, only not neurologically, but throughout from tongue to toe, all the way through. And I'm going to remind everyone, and this is the same article as before, same reference, but we're going to hit it again. The lingual frenulum is a fold of fascia, not a band, and that fascia is continuous through the entire body. And it's the balance between mobility and stability that we are looking for. So if we create a scar under the tongue, trying to remove a restriction under the tongue, well, we might not be doing as much good as we think we're doing. Because this is the research that shows that if epimysium is disrupted, the structure, the hyaluronic interface is obliterated. And first time I read this, I was like, oh my God, I feel so bad if I didn't do something right on a patient. But then I realized we're all on a journey. We're all learning this. But now that I know this, I have to do better. Because this fascia just isn't under the tongue. The buccopharyngeal fascia is super important because if it's restricted from auricularosaurus to buccinator to scleropharyngeal constrictor, which is the airway corset, it's the only true ring of fascia and muscles pulling that mandible back. And how many of us are trying to get that mandible to come forward on patients? Almost all of us. And look at all of the impact on the different functions that we do and the cranial nerves involved. So scleropharyngeal constrictor is the airway corset, which is why cone beam interpretation of airway is not as easy as a lot of people would like to advertise it being, because if the scleropharyngeal constrictor is being activated, the airway is going to look small just because they might be swallowing or they might have excessive tone in the airway corset. Think about bingo arms. Think about toning those muscles. If there's tone in the scleropharyngeal constrictor, it might be able to hold itself up and not collapse at nighttime. But if it doesn't have tone, which is one of the things that oral myofunctional therapy can do, is building tone in the pharyngeal constrictors, we might be able to help that patient breathe better without a breathing tube or a piece of plastic holding that jaw forward. And when you guys get a chance, look at the mandibular labial tendon. That's another big blind spot that we've been dealing with. And there's an orthodontist, God bless her. She put herself in the cone beam machine 3 times in one day and had, while she was swallowing or breathing in and out, she had 3 different volumes on the same patient on the same day. And it's referred to as an airway to die with or an airway to die for. One that you would love to be able to show as treatment results, and another one that you want to send to the hospital right now for surgery because there's no way you're going to be able to fix it. You cannot determine dynamic functional airway on a static image. Think about the box that we're working in and look at all the trigeminal innervation to the dura. And these are the same cranial nerves we're working with. And this is a locus coeruleus that talks about how that part of the brainstem takes input from the trigeminal system. And if there is an imbalance in the trigeminal system, it starts activating all of these other things to be able to compensate for them. This, in my opinion, is the source of adaptations and compensations that lead us to the very difficult challenges that we deal with in whole body dentistry. But it's also our savior, because what they did is they created balance in the trigeminal system for patients who are going through neurocognitive changes, and they were able to reverse neurocognitive changes, reverse Alzheimer's disease, and they did it in normal patients and affected patients. And that's why we can stim and tone the cranial nerve system, especially the trigeminal, to help overall brain function. And this is a picture of one of the ALF designs that we're stimming and toning bilaterally the 5 cranial nerves at midline. This is the research. I'm not going to go through it at length, but take your time to look through it. Basically saying the cranial nerves, and we're all dealing with them in our practice, that we can use it for vagal nerve tone, cranial nerve tone. It helps with postural sway stability. It helps with vestibular dysfunction and vestibular improving functional visual stimuli. Now, this research is electrical, but when you extrapolate that to what we're talking about, we're still neuromodulating, and the patient doesn't have to be aware of it. Perception is not necessarily a prerequisite for neuromodulation. So the question is, are we doing it a positive way or a negative way? Are we helping them or hurting them? Are we pushing the tongue down? Are we inviting it to go up? Because this is in line with modern neuroscience. And welcome to evidence-based medicine. This is where we are. We can help patients live better lives through quality of life improvements as well as the other things we can measure. And this is my face when I have to look at some things on Facebook that I know are not in alignment with best practice. John Remmers just made a statement, and I'm quoting secondhand, but basically what he said is that AHI only determines insurance reimbursement. Even Christian Guilleminault regrets putting a number on AHI. It's an outdated metric. We need to be looking at quality of life. Intermolar distance, if anyone has research, please share with me of that magic number that is out there, because I would like to think at a certain height and weight, everyone would have a certain shoe size as well, but that is not the case. It should be individually determined on what that patient needs, not a metric that is not for a patient phenotype. People are using tongue tie releases, especially in my community. And one of the providers, she's using like Frank's Red Hot sauce and putting on everything, thinking it's going to be better in just like 2 seconds. Like just come in 2 seconds, I'll fix it all. But I see the patients afterwards, and it's not always good. I've already discussed that one. And the role of clenching to open the airway, another big fallacy. It's not true. I love Betty White. Get 8 hours of beauty sleep, 9 if you're ugly. Glial cell function in stage 3 sleep is important because that is the only time we can take out the trash in the brain. So we're not even looking at stage 3 sleep if we're just looking at AHI. We're missing the boat. We need to be determining if these patients are having good quality stage 3 sleep, because this is the NeurGuard study that talks about it. And the impairment of the lymphatic system will negatively impact our patients' long-term quality of life. So where's the choke point in the tongue tie? What if there's a neurologic primary, but we're not looking for it? We're only using choke point. Where is the collapse? Where are we going to do a drug-induced sleep endoscopy to figure out where it's collapsing? Or can we look to the brain? Trigeminal cardiac reflex is a whole 2-day course. It is something I really want you guys to look into. If anyone is really interested in digging deeper, please email me, and the email address will be at the end, and I'll put together the best presentation I can for this organization, because it is something, well, now that I've been looking for it, there are so many patients misdiagnosed with sleep apnea, because when you have a neurologic stimulus through any branch of the trigeminal for someone who has an active trigeminal cardiac reflex, there's an almost simultaneous tachycardia and bradycardia, and that bradycardia is an apnea. But it's not collapsibility. It is neurologic primary. And we have these patients in our office. And there's the things that we need to look for. I don't have time to go through them, but it's where the music is coming from with patients. And it happens with little kids, little bitty kids that are clenching and grinding their teeth and bending those condyles because they have a neurologic primary and they're falling between the cracks. Because sometimes we just don't know what we're looking for. We're trying to help, but we're crashing. The tongue's not connected. We don't know whether it's form or function first. But where's the research for everything? It's everywhere. But you have to look and you have to be discerning. In clinical equipoise, I got kicked off of a Facebook group. It was an oral myofunctional group from a well-known speech and language pathologist, because I was talking about quality of life metrics for what are important to me in my ALP community and my practice. And there was an orthodontist who was like, but how many molars or millimeters of intermolar distance? And they basically called my ALP community, basically, we're a cult. And I said, clinical equipoise makes me question your research, because humans are very difficult to measure. There's too many variables. We have to look at the research, and we're doctors and we should act like it. And a lot of people don't actually know what evidence-based medicine is. So I'm in the front row having fun with this and figuring it out, taking my lumps, helping people. But there are a lot of people in that third row that are like, I'm not going to do anything unless the literature says specifically what it is supposed to do. I want to remind you that evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of modern best evidence in making decisions about the care of our patients. And it's not just about the literature. It's about the skills, literature searching, application of evidence, and evaluating the clinical literature. It's lifelong, self-directed, problem-based learning, which caring for one's own patients creates the need for clinically important information about diagnosis, prognosis, and other clinical and healthcare issues. And it is not a cookbook. It is not a recipe. So what might you be missing? Everyone's trying to measure things, but not everything that counts can be counted. And there is a difference. Everyone believes in things we can't see on Sundays when they go to church. And Monday morning, they're like, show me the data. Sometimes we don't have to have evidence if we know that it makes sense based on a principle. And adults are simply children with complex unresolved issues. We are dealing with the tip of the iceberg with what we know. And this is what I explain to my patients about tongue tie and my understanding of it. We can only see the tip of the iceberg and the frenulum of the tongue, but the fascia underneath it and neurology that's underneath it. This top of the iceberg is not what sunk the Titanic. It was everything underneath it. Retained primitive reflexes, same thing that happens with a child. It could be a 52-year-old that has a problem, but it's the same solution. There's so much to learn. Please keep learning. Surround yourself with people that challenge you how to think, not people that just agree with you. These are the things that I want you to be looking for. Ask your patients to do the posterior palatal seal. Look at the uneven lift. Look at that discomfort of the floor of the mouth. Take your finger back there, gently palpate that. You're going to be surprised how many people are sore. That's a fascial restriction that needs to be addressed. Look at that ipsilateral side if they have discomfort of the suboccipital triangle, because that fascia is now involving the neck. And if the neck isn't straight, tongue cannot work properly. Discomfort when stretching the buccopharyngeal fascia and orbicularis oris. And look at the starfish assessment, which is the assessment for Moro, which you'll learn more about with the resources that I'm going to share with you. Tenderness of the floor of the mouth could have a potential neurological origin for a tongue restriction, including Moro, retained primitive reflex, and cranial nerve dysfunction, along with others. And resolve those unresolved cervical strains before you do any kind of tongue tie release. Everyone understands physical therapy. 8 to 12 weeks following a car accident, we want to increase range of motion, blah, 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 blah. But we're not doing the same thing with tongue tie surgeries, which is why I want you to reach out to your oral myofunctional therapist, work with them, but work with the ones who want to work with you. And they get that you're doing a therapeutic approach and not just a slash and dash. What I use as the analogy with when I teach oral A's is that when we go in there and we reset the cranial nerve system with this laser, non-surgical laser, it's like an AED, resetting the rhythm of something that's gone wrong. CPR is the manual therapies, which is the stretches and releases that we can do, our therapists can do, and our patients can do for themselves. And then the pacemaker is the stimming, the continual or intermittent wear dental appliances to support positive proprioception. We want to provide stimulation, encourage mobility, and reduce rigidity. Rule number 1 is first do no harm, but some of our patients have been harmed. And that's the research again about the scarring that happens sublingually, which can negatively impact the airway as well as tongue function because of the swallow function and the trauma that is involved. And I don't want you to go nowhere fast the next right. I want you to be able to understand that there are a lot of dots that we can connect. We influence the teeth influence the brain, the teeth influence the mandible and the maxilla through every bone in the cranium. The pressure placed on the bones through the oral neuromusculature affects the dental and cranial sutures, and the teeth influence the tongue through natural signaling of having a safe place to be. The tongue influences the brainstem bilaterally through 5 cranial nerves and influences the cranial vault and the mandible and the teeth through the swallow and rest posture. Buccopharyngeal fascia also interacts with the floor of the mouth fascia to influence the entire body. Oral appliances affect all of those things, especially if they have that rhythmic oscillatory movement that the body recognizes as natural and normal, and it welcomes it. And that helps the cerebral spinal fluid movement, facilitates glial cell function, and helps improve the chance of the patient not suffering from neurodegenerative conditions. And if we idealize that natural signaling through positive proprioception, we might be able to help that autonomic nervous system homeostasis, which is the basic hierarchy of needs of what we're trying to do. So do you want to take a chance at being part of the problem instead of part of the solution? And are you sure that you have all the training you need to be able to handle all of those? Or maybe you need to explore some more possibilities. So we're going to bring it full circle. Neurology, airway capacity, sleep architecture, trauma, oral myofunction. And the only thing that doesn't change is change. Hopefully this is a safe place for you to look at some things, maybe do some modification of your thought processes. These are my passions. I'm going to put in a quick plug for my ABCDSM as the president of this organization. I want people like you to be able to join us, to be able to help get to the bottom and problem solve. And our credentialing process isn't very easy, but we are an elite group of people who are really proud of what we do. It's not impossible, but it is totally worth it. Academy of Craniofacial Pain, these are my tribe, the people that love helping their patients through helping the body help itself. I teach through the Synergy Academy, the Alpha Interface Academy, oral A's and baby lays. These 2 procedures have changed my practice and my quality of life as a dentist and helping my patients recover. So thank you for sharing your time, challenging your paradigms, considering your blind spots, and opening your mind to new possibilities. We are probably out of time because I had so much information. So please, Shaylin, if you have a few minutes, we want to go ahead and open up. These are the two websites. Feel free to go ahead and take a picture of it for the resources and any additional information on those invisible influencers and basically the primitive reflex integration and the middle dental connection. So thank you guys very much.
Thank you so much, Dr. Tenholder. That was awesome information. We do have a few questions. I don't know if we'll be able to get through them all, but maybe we can at least start them if you're okay with that.
I'm completely fine with that.
Awesome. First question, how can you discern what the true restriction is? Facial, neurological, soft tissue, and then what?
That's really challenging. That's something I'm probably not going to be able to give you an answer to in this webinar. We are going to be developing a course for that, and it looks like it's going to be Veterans Day weekend. So anyone who's, we teach it obviously already part of the Synergy Academy for those going through laser training, but I am going to develop a course just for anyone who wants to come and understand the very simple things we can do that, and like I said, some of it's on the website already, but we'll be showing you those in the course. I wish I had an easy answer, but it is not easy.
Okay, next one, if nothing changes functionally with a tongue restriction after myofascial release and a restriction remains, what other intervention should be explored before proceeding with the release?
I'm a big fan of making sure that a body worker has said that the cervical spine is idealized, that the primitive reflex system is normalized, which means they don't have a startle response. They don't have anything pulling that body crooked. And once you have idealized that, there's no tenderness under the tongue, the neck is good, the reflexes are good, then that is when I say, okay, there are really inelastic fibers that we do need to go after. But if we remove all of the other obstacles first and we get muscle fiber lengthening, we get especially the muscles of the tongue have to know what to do when they're released. So that's why working with an oral myofunctional therapist to teach the tongue the possibilities before the release so it can do it when it is released. But every patient is going to have a different phenotype coming in. So to be able to answer the question as succinctly as possible, identify any of those neurological restrictions, address them, get the fascia moving so where it's not sore. You've increased range of motion to the best of your ability, but there's still a restriction. Then address the surgical aspect of it. But the nice thing about doing it that way, it's much more conservative when you do a surgical approach because the fascia's already been released. So all you really have to see, and is much more conservative, are those inelastic fibers. Makes your surgical approach much more conservative.
Knowing all of this and agreeing with neurological as primary is often missed. How do we best help our patients as professionals? And this is coming from a myofunctional therapist.
That's an awesome question. I think education is the number one thing. And that's why in that holistic orthodontics website, I've put a lot of references in there so patients can go in there. My parents are my co-therapists. There's a website link in there. It's called solvelearningdisabilities.com. The parents can do these exercises with their kids, identify the retained primitive reflexes, do the exercises to overcome them. And then if they can't work through it on their own, they find an occupational therapist or a physical therapist that can help them. But educating patients on the options of addressing the neurologic primaries before a structural approach is taken is, I think, the number one thing you can do to help your patients.
Okay. If someone has scoliosis that begins at the C-spine, how can you resolve the cervical restrictions to allow the tongue to work?
That's a fantastic question. I have a really challenging set of twins that has scoliosis in my office and another one that is getting ready to have surgery. It's very difficult because if that fascial system is tight from a neurologic primary, you should be releasing that fascia in conjunction with the body worker to get it as idealized as possible. But a lot of these kids will take off on a growth spurt and the twists and the turns happen more quickly. So you have to realize that if you do an approach for a tongue release that is more conservative, you're going to help that patient move through it more gracefully as opposed to something rapid. But you're working with a team approach. The body worker says that it's good to go, then the neurology is good. you might need to do a surgical intervention to help them. And that might be upper C-spine. And it's usually, the body braces for the kids with scoliosis. What's really hard is I have a torticollis patient, same way. We're unwinding him, but we're using oral mechanics to be able to help that, to stabilize the ability for that cervical spine to normalize by helping the bite. But that's using that reflexive system to trick it into being at midline when it's not yet. And I know that's a complex answer, but it's also a complex question. So I think it's another one of those, I'm trying to give an answer to something that it's much easier for an individual situation to address as opposed to a generalized question. But the system working together, decompressing the cervical spine and allowing things to unwind gracefully as opposed to rigidly and rapidly, usually help the scoliosis patients better than a very aggressive approach.
Okay. And last question, what laser is baby lace?
Both baby lays and oral lays are actually done with a 1064 nanometer laser. There's two lasers that can provide the service. Both are sold and distributed through Photona. The Lightwalker ATS is the laser that is the most accessible. And basically it feels to the patient, when we tell the littles, like a kiss from the sun. But little nonverbals, we have to start low with the dose, but it's a very specific sequence of warm light, and that 1064 frequency is specific for being able to, the chromophore is hemoglobin when we're doing this, it's pigment. So it's heating up the muscle from the inside, which then liquefies the hyaluronic acid restriction between the deep fascia and the muscle, and allows the neurologic connection to happen basically immediately. So immediate relief of pain, immediate increase in range of motion, and immediate neurologic connectivity. So using that 1064 nanometer laser is the only thing that we know of at this time that can achieve the results of baby lays and oral lays.
Thank you so much again, Dr. Tenholder, for your time, all of your information, and thank you, of course, to everyone in attendance this evening.
Well, thank you very much. You guys had some great questions. I hope that the answers were helpful. Feel free to reach out to me. The email is down there at the bottom. And if there's any way I can be of any help, I would love to do that for you guys. Thank you guys so much. Have a good evening.
Thanks.